So welcome all, and we have this IC which has been successfully running for the last 3 years. So we have the only Harry Potter with us because he's the only male gender. So Siddharth is our Harry Potter, and his team is back to fight the Voldemort of glaucoma with stronger treatment tools. Can I have the first slide of introduction, please, in mine, audio visual? मेरे presentation में first slide होगी introduction of the speakers. कीर्ति सिंह के नाम से होगी. We have time, so या आप मेरी लोड कर दीजिए. I'll just show it. हाँ करा दे. नहीं आ जाएगी अभी. करा दे. वीडियो वाली लोड करा दे. नहीं इसी में होगी ना. मैंने डाली थी. It's there.
नहीं मैम, it runs from the back end. इससे directly नहीं निकलता है.
He needs to anyway check it out. Please check the presentations then.
I have that PPT, the one that ma'am's talking about. If you can run this one, the intro.
Put it on this laptop.
It's there on this one.
There on.
It's there on this one.
Yeah, you can give.
I can
access
run
to
it if. Yeah, this one.
So let me introduce our team of Harry Potter's team. So we have Major General Sagarika Patyal from CFS Delhi. There's me, Professor Kirti Singh from Guru Nanak Eye Center, New Delhi. There's Dr. Anu Choon, again from Guru Nanak Eye Center, New Delhi. There is Dr. Siddharth Dikshit from LVPI, Hyderabad. There is Dr. Vanita Pathak from CFS, Hyderabad. And there is Shaina Wumpla from Dr. Shroff Charity Eye Center, Delhi. And we'll be covering these topics: rational use of anti-glaucoma medications with a special eye on conjunctival health, constant vigilance, as Alastair Moody used to say, and that will be covered by Dr. Shaina. Strategies to detect glaucoma progression, perimetry or imaging by the planner Albus Dumbledore, which would be Dr. Anu Choon. Lens and iris parameters redefine surgical options and outcomes in ACG, the Jinxer of Voldemort by Ginny Weasley, which would be me. Long-lived trabeculectomy, modifications for longevity and safety, erudite Hermione Granger, which would be Dr. Sagarika Patyal. Tube shents are here to stay, but when? Artake, transfiguration master, Professor McGonagall, which would be Dr. Vanita Pathak. And let's dare to grow bleb-free. Schlemm's canal surgeries are experience. The always daring Harry Potter, which would be Siddharth Dikshit. So you've heard a lot about Schlemm surgeries and mix, but here is a different perspective, and the other perspectives are of something which we do day in, day out for glaucoma surgeries. We put our experience over the last 2-3 years to give to you what we feel in our experience is a little better, keeping in mind the conjunctival health and complications. So hoping that this will help you in making decisions for glaucoma, which all of you have to treat at one time or the other. So thank you, my team. Over to Dr. Shaina.
Good afternoon, everyone. At the outset, I'd like to thank AIS and Professor Kirti Singh for giving me this opportunity, and I also sincerely extend my gratitude to Dr. Monica Gandhi, on whose behalf I'll be presenting. I'll be talking about the rational use of new anti-glaucoma medicines with eye on conjunctival health. We all know that the mainstay of treatment for glaucoma has always been medical. For almost 70 to 80 years, there was only one anti-glaucoma medication that we majorly had, that was pilocarpine. And then many years later, in 95, 96, we started having alpha agonist, beta blockers, prostaglandin analogs, and carbonic anhydrase inhibitors. And almost 21 years later, in 2017, we found the Rho kinase inhibitors and the latanoprostene Bunod. Managing glaucoma in elderly patients poses challenges as they are prone to dry eye already, which is further worsened more by anti-glaucoma medications. Long-term use of these medications is necessary due to the chronic nature of glaucoma. This is a patient whom I asked to show how he puts his drops. You can see the nozzle is not even reaching the eye, and the drop is almost entirely spilled over the lids. I'd be daring to show a few terrifying pictures of the side effects, and more pictures than text, because I believe that pictures speak louder than words. The lengthening of lashes, typical of the prostaglandin analogs. This patient developed drug-induced cicatrizing conjunctivitis. You can see the severe periorbital dermatitis, eversion of the lower lids, and severe congestion of the palpebral conjunctiva, and this eversion here as well. This is another patient with very severe allergic dermatitis after the use of anti-glaucoma medications. This was a patient on Rho kinase inhibitors for more than a year. You can see the abnormally dilated vessels. There's a lot of conjunctival hyperemia that happens with almost all anti-glaucoma medications, but the one with Rho kinase inhibitors is different, and these look like a few very dilated vessels. Another side effect with Rho kinase inhibitors is the reticular corneal edema. However, this one is reversible. Also, some spontaneous small subconjunctival hemorrhages, which are mostly petechial after the use of Rho kinase inhibitors. If you notice, this is the long list of only the ocular side effects with Rho kinase inhibitors reported in the ROCKET-2 trial. Majorly conjunctival hyperemia, conjunctival hemorrhage, lacrimation increased, conjunctival edema, allergic conjunctivitis, and drug-induced cicatricial conjunctivitis. This is the pooled analysis of the Apollo and Lunar trial. Even in this, with latanoprostein bunod, the most common side effect was conjunctival hyperemia. If you look at this patient, the eye which does not have AGM and the eye which is on AGMs, you can notice the increased congestion so much in the eye on AGMs. Another patient with such severe allergic dermatitis and also this severe congestion of the lids. This particular patient has been one-eyed and has been on anti-glaucoma medications for more than 2 decades, and I've never seen a case as severe as this far in my short span of career. Such severe allergic dermatitis and very, very severe conjunctival congestion and hyperemia. Another patient of drug-induced cicatricial conjunctivitis, eversion of the lids, and the sharpened lid margins have started to round-in, and very severe congestion of the palpebral conjunctiva and the allergic dermatitis. So this picture typically describes this eye which has undergone TRAB and is not on AGMs. You can see the conjunctiva looks so much better than this eye which is still on AGMs, and there's so much of congestion and hyperemia in this eye. Another patient of drug-induced cicatrizing conjunctivitis, where this is the early formation of symblepharon and fornicel foreshortening. Other features found in drug-induced cicatrizing conjunctivitis would be keratin deposition at the lid margins and punctal occlusion. This same patient, after receiving a tube implant, if you notice, the conjunctival hyperemia and congestion have reduced considerably after stopping the anti-glaucoma medications. Another patient, you see this eye, only the lateral part, the lids have started to evert so much. So then we found a few patients of ocular cicatricial pemphigoid with deposited keratin over the lids, and we didn't know what AGMs to give and what to do. And you can't always give oral anti-glaucoma medications, and also how long will you give it for. So these drops, they definitely affect the quality of life and also increase the prevalence of ocular surface disease. There's a study which says that for each additional eye drop preserved with benzalkonium chloride that we prescribe, there's a 2 times increased risk in the likelihood of experiencing ocular surface disease. These are the preservatives that we commonly find in anti-glaucoma medications: benzalkonium chloride, purite, Sofzia, and polyquaternium. Benzalkonium chloride is found in almost 70% of the anti-glaucoma medications. It's not only the most commonly used, also the most toxic. It reduces the survival of corneal, conjunctival, trabecular meshwork, ciliary epithelial cells, promotes ocular tissue inflammation, causing symptoms like pain, discomfort, tearing, as well as signs including increased ocular surface straining, worsened Schirmer test scores, decreased tear film breakup time, high prevalence of punctate keratitis, overall worsening of ocular surface disease index scores. These adverse effects are, of course, dose dependent, worsening with increasing exposure to benzalkonium chloride via multiple medications and multiple drops per day, and also the long duration of therapy. Also, the long-term use of BAK preserved medications reduces the success of subsequent glaucoma filtration surgery that you might be doing. Purite and Sofzia are called the vanishing preservatives. Purite is a stabilized oxychloro complex which degrades to chloride ions and water upon exposure to UV light. It's used in alpha-GN P. Sofzia is an ionic buffered solution consisting of zinc, borate, propylene glycol, and sorbitol, the compounds that sustain to maintain an antimicrobial environment in the container, used in Travertin Z. Then to our rescue came preservative-free drops and combination drops. Combination drops where you have either two anti-glaucoma medications in one drop and now even 3 with an Indian company. The merits of these would be that the number of drops per day would considerably decrease, obviously improving the compliance of the patient and definitely leading to a better quality of life. You're also lowering the burden of preservatives in the conjunctival cul-de-sac. So this was a patient on multiple medications, and you can see the severe allergic dermatitis and such severe congestion of the lids that he has. And after 10 days of giving him preservative-free AGMs and steroid ointment for local application over the lids and copious amount of preservative-free lubricants, he improved considerably. I have no financial interest. These are the names of a few preservative-free drops available in the market. However, they also are a little expensive. They're administered in the form of single-dose units called Unims or Novelia and Aptar bottles. However, these bottles also have a few side effects of their own. It's very, very difficult to administer drops with the help of these bottles, because once you squeeze, either patients find it very difficult to try to get that one drop out, or if you squeeze too much of medicine flows out, and again, a lot of financial burden on the patient. Yesterday in this hall itself, there was a question raised that if the preservative-free drops are causing lesser side effects, are they even as efficacious as the normal ones? So then I went back and I tried to find few studies, and these 3 studies I found where they said that the IOP lowering effect of the preservative-free AGMs was non-inferior to the preserved AGM, indicating that benzalkonium chloride is not required for the adequate drug penetration, in line with other studies demonstrating equivalent efficacy between benzalkonium preserved and preservative-free glaucoma medications. So I had really wanted to include a video of the correct technique of putting preservative-free AGMs. I think all of us have to take out the time in our busy clinics to try to teach the patient how to put this AGM.
चाहे तो आप पानी से भी धो सकते हो और इसको आप खोलेंगे, इसको टच नहीं करना है, ठीक है। दवाई हमेशा बैक कर डालना है, ऊपर रखेंगे, ये खींचेंगे और ऐसे एक बूंद डालेंगे, उसके बाद आँख बंद कर लेंगे और ऐसे 2 मिनट दवाई, ताकि दवाई शरीर में न जाए, आँख में जाए। अगर
Thank you.
Thank you, Dr. Shaina, for covering that very important thing. We all are dependent on anti-glaucoma medications. If we just take the time out to explain to the patient, and you've seen the pictures of all the problems which can happen. So that's a message that we need to be cautious while prescribing, to not over-prescribe. And please remember that all of us are surgeons. We can do TRAB early or any surgical intervention early. We'll take the questions at the end, please. Then we have now Dr. Anu. I'll be asking Dr. Vanita to introduce the topic.
Yeah, Anu will be talking about new strategies to detect glaucoma progression, perimetry or imaging. And she's, of course, Alistair Moody.
Oh, yeah. So I've got my magical eye on so that I can catch these Death Eaters of glaucoma progression and nip them right in the bud. Now, which tools shall we use? Shall we use the wand of perimetry or a fog glass of imaging? Everybody? All right. So we all know glaucoma progresses from an undetectable disease stage to an asymptomatic disease and then goes on to functional impairment, starting from the ganglion cell death, which reflects early on to the RNFL damage and later on to the perimetric damage. We need to have a constant vigilance on the risk factors of progression, and patients with risk factors need to be followed up more thoroughly with any investigative technique that you choose. Structural progression can be done assessing the OCT with various tools such as RNFL thickness and the optic nerve head parameters, and also the later added parameters such as the macular ganglion cell complex, the ganglion cell IPL thickness. And functional progression can be detected using visual fields, that is perimetry, and the newer tools of glaucoma progression analysis. Progression can be detected either clinically, or it could be an event-based or a trend-based, and newer modalities like AI are also now stepping in. Detecting progression in a mild to moderate glaucoma or a patient who has no glaucoma going into an early glaucoma is a no-brainer. The OCT offers the advantage of being objective and precise, with the limitations of structural variability in healthy eyes. An overlap may be present between the healthy eyes and early disease, A normal age-related structural loss can confound interpretation, but most importantly, the floor effect that I'll be coming upon briefly. Perimetry has the advantage of detecting the functional damage, which is what the patient cares about, but with the limitation of being subjective, sometimes poor reproducibility, especially in patients who are poor field candidates. A longer series of tests are required to assess progression on perimetry, and sometimes it does get better with time, thereby decreasing the sensitivity to detect progression. Now, in the early stages of the disease, the structural and the functional changes often disagree. The structural changes come in early, and the variability in automated perimetry is higher. But there comes a tipping point in this disease severity, after which there's stronger correlation between the two, or maybe even a reversal. The OCT becomes less sensitive than automated perimetry. I'm talking about the classical OCT of the RNFL thickness in detecting progression due to this floor effect. And various studies have highlighted this importance, showcasing that OCT RNFL fares better in mild to moderate glaucomas. However, most studies say that not all the investigative technologies will detect progression. You may have progression documented in 1 or 2 tests, but not on the 3rd test. The study, which is quoted here, studied almost 64 patients, and they come to the conclusion that only 10 of the patients had progression on all the 3 parameters. Now, challenges in advanced glaucoma is that you have very few progression endpoints to monitor. Floor effect is a level for any given technology below which further disease-related changes become undetectable. In perimetry, a mean deviation of less than -20 decibels is typically known to be reaching the floor, whereas in SD-OCT imaging of thickness of less than 50 to 60 microns is classified as a floor. A study which analyzed the structural functional relationship in 147 glaucomatous eyes over a period of 3 years by studying the serial visual field testing, the RNFL imaging, and the macular OCT imaging, came to the conclusion that there was significantly more OCT progression endpoints than there were on the visual field. And detecting progression using all the 3 modalities, again, was uncommon and was seen only in 7% of the eyes. Now, what are the factors which confound this structural functional agreement? The analysis method used by these technologies is different. There are differences in the measurement floors and higher prevalence of artifact and variability in severe glaucoma due to reduced data signal. So when we're talking about advanced glaucomas, it becomes important to detect localized change and change over time by analyzing changes in the central sensitivity values. Central 10-2 testing becomes important because it studies almost 68 points in the central 10-degree fields, and larger stimulus size can definitely be used to detect progression on those particular points. Repeated testing and more frequent testing becomes important to compensate for more artifacts in cases of severe glaucoma. And studies have demonstrated that changes in the central 6 mm of the macula show excellent correlation with 10-degree visual field testing. Now, talking about progression on perimetry, it is usually studied with glaucoma progression analysis, which can be of 2 types, that is the event-based and the trend-based. In event-based, progression is studied as either present or absent based on a predefined change in the parameters. Point-wise glaucoma analysis plots are done, and a significant deterioration in the plots at 3 or more points on 2 fields subsequent is possible progression, and on 3 subsequent tests is likely progression. This is after a baseline of at least 2 fields. But these become unimportant or may have confounding factors with mean deviation less than 20, as we talked about the floor effect in perimetry. So you can see there was a progression in the first fields compared to the second fields. This is outside the test base fields. So this showed a possible progression, and when it is reflected on the third field, it becomes a likely progression. However, trend-based analysis has come more into the picture with visual field index, which was introduced by Benston and Heil in 2008, and it gives the percentage of visual function which is corrected for age. Not only does it tell how much of the field has been lost, but it also predicts the rate of progression and helps to differentiate rapid versus slow progressors. Talking about OCT, the longitudinal analysis of OCT macular and ONH parameters have shown to detect structural progression even when peripapillary RNFL have reached the floor effect. So the talk about OCT reaching a floor effect and perimetry being better gets null and void here when we talk about the OCT macula and the ONH parameters. In a study of a cohort of advanced glaucoma with mean deviation of less than -20 on perimetry, they showed that GC-IPL thinning was noted in almost as high as 31% of the eyes. And macular OCT parameters do definitely provide an alternative for objective and quantitative monitoring of patients with advanced glaucoma who may have retained their vision and functional assessment cannot be done. So you can study macular GCC scans in various quadrants, and GC-IPL thickness can also be calculated. ONHQ parameters like the rim area, disc area, and CD ratio can be analyzed, and event and trend-based analysis can also be studied on the OCT parameters. An important point here is that lower baseline scans are required in OCT compared to visual fields because of high artifacts and poor reproducibility in the visual fields being a subjective method. Newer swept source OCTs which have a deeper penetration help in imaging of the choroid and the lamina cribrosa, which may in future help to individually visualize the RGC layer. The most upcoming strategy to monitor progression is the OCT angiography, which studies the movement of the red blood cells and allows for evaluation of peripapillary, ONH, and macular vasculature at various depths, exposing several vascular networks. Studies have shown that in eyes with glaucoma and a single hemifield defect, decreased vascular density has been noted in the macula and the peripapillary regions, even in the other unaffected hemifield. So in a study that was done at our center, in studying the retinal structure and microvasculature in symmetric advanced glaucomas with 0.8 or 0.9 cups in paired eyes with visual asymmetry of 2 or more lines by Dr. Kirti Singh and Dr. Shraddha Srivastav. They studied the parameters of OCT RNFL, OCT macula, GCC complex, and octa parameters in the various layers, and there was a definitive indicator of an improved macular GCC thickness in the eyes with better vision, which was even more significant in the octa parameters. So the better eye vision had better vascular density compared to the poorer eye visions. You can see a large number of vascular dropout areas in the poor visual eye in these cups which had symmetrical cupping. And sectoral analysis also revealed that papillomacular bundle sectors had a better correlation with the visual acuity. The GCC was found to be superior to RNFL in predicting visual loss in advanced glaucoma as per the Auroch curves. We also have experimental OCT systems coming in like the Doppler OCT and the visible light OCT, which claims that they'll be able to detect the pruning of the RGC dendrites as an early indicator of glaucoma using adaptive optics with the SLO. Novel biomarkers are also coming up in this field to study the direct measurement of the retinal ganglion cells using fluorescent tagged cholera toxins, fluorescent labeled CGA MP3 cells, and also detection of apoptosing retinal cells. However, the future of detection of glaucoma progression does become an AI. AI right now is used only for detection of glaucomas or early progressions, but in advanced glaucomas, it will come up in a big way as studies are already underway. So in conclusion, I would like to say that following up with perimetry is important, but in advanced glaucomas where perimetry reaches a floor effect, OCT, macular GCCs, and octa parameters do play a very important role, and patients can be followed up on that. Thank you.
Thank you so much. I think you give a very vast and very good understanding of the subject. Thank you very much.
Thank you.
And now invite Professor Kirti Singh. I'm not going to say that she doesn't need an introduction because I feel that everyone needs an introduction. And Professor Kirti Singh is the chief of the glaucoma services. She's chief of GNEC Guru Nanak Eye Center. And I've known her since a very, very, very long time. I've seldom seen a person with so much courage of conviction and the wanting to do always, wanting to go ahead in learning and understanding glaucoma and passing on this training to others. Over to you, Dr. Kirti.
Thank you for those kind words, Sagarika. So, we are Indians. And we cannot extrapolate Caucasian data to eyes because glaucoma is very much defined by ethnicity. And we have found in our eyes that lens and iris parameters do redefine surgical options and outcomes in angle closure glaucoma. I have no financial interest to declare. So we do know all these figures by rote. But please remember, angle closure glaucoma is responsible for 50% of the global glaucoma blindness. And we as Asians have 3/4 of the PSCG population, and India is pretty much so. Coming from New Delhi, over 4 decades experience in glaucoma clinic, seeing around 4.5 lakh patients per year, we found that angle closure glaucoma in our setup is at least 45 to 50% of our cases, and our patients which are this type come to us with severe visual field defect in 50% and legal blindness in 37%, which is a huge number. And we just wish that it could have been picked up early, but it doesn't happen. So once it is picked up, and these are the type of patients who are going to have all these issues of dependency on an escort and financial status and poor health care, what can we do? So let's look at some established facts. We do know that the topography of the ICG eye, it's a small globe, lens volume is exaggerated, anteriorly positioned, there's angle crowding. This we do know. But the new facts are about the lens vault, that this lens vault is the perpendicular distance between the anterior pole of crystalline lens and the horizontal line joining the two scleral spurs. This increased thickness and bulk of lens anterior to scleral spur plane pushes the peripheral iris against the trabecular meshwork, worsening the angle crowding in predisposed eyes. It doesn't happen in every eye, but in the predisposed eye. And these are the studies which say that PSCG vis-a-vis normal and PSCG vis-a-vis POAG, they found that the lens vault to be significantly more, so much so that this term came to be coined as volcano configuration, which was the exaggerated lens vault, which came to be identified as an independent risk factor for angle closure glaucoma. Another established fact is that angle closure glaucoma is signposted very often by these iris signs. We've learned it from the textbook, ectropia on UVA, sphincter atrophy, whirling, and all those things. And these iris clues will tell you that angle closure attack has happened in these eyes. But what is now being found out that there are different mechanism of iris, especially the thick peripheral iris roll in addition to exaggerated lens vault, and the iris is bulky, flaccid, floppy, atrophic. Pupil, of course, is very often non-dilating, so much so that this editorial which I found, that the iris behaves like a sponge in angle closure glaucoma by way ahead 10 years down the line. Now it has been identified that there's a pinch region between the posterior iris surface and the anterior lens surface, which is determined by both the lens size and the iris configuration. And these quantitative iris parameters, which OCT has made it possible for us to do, which is iris curve, iris area, iris thickness, are again independently associated with narrow angles after adjusting for age, gender, angle, and anterior chamber depth and axial length. However, there remains a difference of opinion. The Chinese eyes, the Singaporean group said that the iris curve is more, iris thickness at 750 and 200 microns is more, whereas in only one Indian study by Dr. Sehota et al. Said that there is decreased iris thickness, but that study was by UBM. So it is like the Voldemort of glaucoma has done a reductio for the angle and the iris and engorgio for the lens. So let's see how we stand. The Singapore group came up with these studies in way back in 1400 eyes, where they said lens vault is highly independently associated with narrow angle closure, and ZAP program customized algorithm was developed by them. Again, that lens vault significantly increases angle closure was again corroborated by the Chinese eyes, and relative lens vault came to be known as a new factor, and this volcano lens configuration came up by both the South Korean group and the Iranian group, which talked about the exaggerated lens vault and the increased iris curvature as being predictive of angle closure. Now, if there's a thick, we always know that plateau iris, the PI doesn't work. But remember now, there's new terminology which has come in, is thick peripheral iris roll, whereas the prominent circumferential folds are seen in 10% of angle closure glaucoma, the PI remains ineffective. And once there is exaggerated lens vault, is there a role of lens extraction? I am not quoting the Eagle study, but this is a different thing altogether. So these 2-3 factors have come up new, and there has been ethnic variation, as the study from Spain showed that whites and Chinese and Hispanics and Africans behave differently. So Hermione came up that, okay, let's see the lens vault, lens thickness, iris curves in eyes of Indian ethnicity, and we did 2 studies of lens parameters in angle closure vis-a-vis open angle, and ACG eyes were 81 and control group were 32 age gender matched angle closure open angles which were requiring cataract surgery. And as you can see, the lens vault was significantly different in the angle closure eyes vis-a-vis the open angle glaucoma eyes, whereas lens thickness was different but not so much. this was corroborated by the graphs again, that lens vault and relative lens vault, not lens thickness, was significantly increased in angle closures vis-a-vis open angle. And these are some case vignettes when you can see the lens vault is so much higher in the angle closure vis-a-vis the open angle glaucoma eyes. So much so that now we've started looking for, and what the mind starts, eye starts seeing, what the mind knows, you can actually see that this is a volcano configuration. You don't need the ASOCT to prove it for you. Then the iris curve and iris area, however, were reduced in angle closure eyes, but we do realize that most of these eyes were post peripheral iridotomy, which were not the case in other cases, other studies. So for these patients, our iris curve was less in the angle closure eyes. The other study we did was of the lens parameters in angle closure vis-a-vis control group, which was pure cataract, no glaucoma. And here also we found that the ACG eyes was significantly having a higher lens vault, higher lens thickness vis-a-vis the control group, and again relative lens vault became to be much more significant. The better parameter was relative lens vault in having the better area under curve. See the few case vignettes again of the PACG eyes and the control eyes. You can actually see at a glance how much is the difference in the iris curvature and in the lens vault. The iris curvature, the iris parameters, again on the comparison that the curve, however, in angle closure was not so much as we expected. Again, emphasizing that laser iridotomy, which we did for all the eyes, did flatten out the iris curve. Post-cataract surgery, the decrease in iris curve was noted in angle closure and cataract, which meant that the iris curvature flattened out after PI and after surgery. ACG eyes had a thinner iris at the 750 microns and 2000 microns, and this thinned even further post uneventful cataract surgery in both the groups, both the control groups and the ACG groups. And again, the area was thinner in the angle closure glaucoma eyes vis-a-vis the control groups. Now, this was the previous parameters, that Chinese eyes had a thicker iris and the thicker iris thickness. However, Dr. Sewota's study said that iris thickness was less in angle closure, and we kind of agree with her study that our eyes in India are lesser. So what are the surgical outcomes? How were they different? The surgical outcomes was that the capsular rhexis in ACG patients with such a high lens vault of 0.89 was pretty difficult. The lens is very flaccid, it's like the capsule is all bulging out like a balloon, and it's very difficult in a shallow anterior chamber to do the rhexis. So you have to be very careful at this stage. I would say the most careful at this stage of rhexis in ACG eyes. The other surgical outcome which is different at that ACG eyes had iris chaffing very frequently, and this iris used to have pigment dispersal and floppy iris, and you have to manage the iris very differently in angle closure glaucoma vis-a-vis open angle glaucoma. And we again reiterate what Quigley said, that iris behaves differently. The other issues was the iris keeps prolapsing out. It's like a floppy iris you have. It's like that, it keeps relapsing out, and we realize after some time to reposit it is pretty much difficult. So what we do is now we just do a surgical PI at that end, reposit the iris, and then carry on with the phaco. Just leave the iris wherever it is. Just don't try to keep repositing it. That will cause more trauma. So this billowing iris and the iris prolapse is very common. It's like it just keeps popping out like this genie. Surgical complications, the other ones which we're all familiar with, is the synechulitis, the narrow pupils, and the iris retractors with the bulging lens. So have iris retractors ready, have all the Malugin rings or whichever ring, because you're going to have these problems. Other thing which we noted new was this iris bleeds, which we see very commonly in ACG eyes, whether it's a TRAB or it's a cataract surgery, which we don't see. So how do we, just 2 slides more. So how is the surgical outcomes redefined? IOP controlled was changed with PACG. It just at 4 months follow-up, the cataract alone caused a 32% reduction, and the requirement of anti-glaucoma medications was there, reduced. Pre-op iris curve was positively correlated with IOP, and the pre-op IT was negatively correlated. So to conclude, lens is bulkier in ACG patients. Relative lens vault is a more sensitive marker. Iris curve and iris thickness in our patients were thinner. Phacoemulsification results in reduction in iris curve. The streep iris configuration reduces from 37 to 13%. AC deepens and significant index of with the ACG cases in ITC. Positive correlation with pre-op eye curve, negative with the iris thickness, and again with the ITC index. So how do we change it? What have we understood? That iris physiology more than anatomy is different, and lens vault can predict the IOP control. So I finish with this quote from Rudyard Kipling: "East is east and west is west, and never the twain shall meet." And remember, when we are Indians, we are dealing with our eyes. We need to keep these 5 factors in proportion and understanding. Thank you so much.
Thank you, Dr. Kirti. Amazing insights into the role of lens in angle closure. I now would like to welcome Dr. Sagarika Patyal, and apologies for the Major General.
No, it doesn't matter. It's all right.
And I'm quite sure with her enormous experience and the rigor of the Indian Army, she'll be able to throw a great light on a very important topic and the most important surgery that we have in glaucoma, trabeculectomy. Over to you, madam.
Thank you so much. And I love being what she has made me, Hermione Granger. And so let's go back into what actually trabeculectomy is. It's been with us for a very, very long time, 1968, imagine. But do we feel that trabeculectomy has shown changes? Yes, it has started climbing steps since a very, very long time. But as on today, trabeculectomy is still the shining star that is waiting to be displaced. Lots of other things have come up, but we know what place trabeculectomy still has. So the goal of trabeculectomy is to create a long-lasting subscleral fistula. Now, why is trabeculectomy so important? Because all age groups can benefit from this procedure. High intraocular pressures can be controlled by this method. There is no need for a clear cornea or angle visualization, no need to learn many more things. But yes, you have to learn how to do the surgery and also look after that little bleb that you have formed, look after and care for it, both by the patient and also by the doctor. What is the final writing on the wall? In terms of incisional surgery, trabeculectomy is still considered to be the gold standard, with tube shunts trailing short behind. Both trabeculectomy and tubes are well-established procedures that have been successfully employed for several decades. Although highly efficacious, now that is the problem, they are associated with intense postoperative care for the first 2 to 3 months, carry the risk of potential vision threatening complications, and this is why we need certain amount of complications. All of us do this surgery. I'm just going to show you a little bit about how do we do it. And it's very, very simple, because we must remember what we do in order to say how we are going to, this is what happens always. Okay, so we are putting in the mitomycin, we're putting it nice with sponges, going further beyond, and after that having a thorough wash, and after the thorough wash again we go ahead and then we go into the actual cornea, and once we have identified the structures, and then after that I make it with my blade, and I don't do it with a punch, but I know a lot of people do it with a punch. Both are equally effective, and once we have done that, and then we cut a nice ostium over there, make a nice ostium, check whether the iris has actually been cut properly, the base of the iris being nice and big, and then after that go ahead, see, pick it up, pull it back, and then after that put in our sutures, and once we have done our sutures, we definitely put in our releasable sutures, and then after that here, I'm putting in my releasable suture, which is so important. And now let us go on, of course, tying the conjunctiva and seeing to it that the flow is actually on. And so now let's go on to, so there are now modifications which have come up on how do you apply the mitomycin. So in 2021, they have talked about, instead of placing it horizontally, parallel to the limbus, they are now placing it vertically, so that it reduces the size of the conjunctival wound at the limbus, preserving more of virgin conjunctiva that can be used for further repeated trabeculectomy. This was only done by one person. Obviously, we would like to have many more studies on this. Now, a subconjunctival injection has definitely come to the forefront by none other than Maheshwari and all, and many other people have started trying it because, you know, we found that little bits of this sponge may get left behind and result in a continuing amount of mitomycin being, the eye being subjected to that amount of mitomycin. So the very important method is to give a slightly lower strength of mitomycin of 0.1 milligram, 0.1 milliliter of 0.1 milligram per ml. You inject it into the tenons layer about 8 to 9 millimeters away or posterior to the limbus, little off, so as to avoid the superior rectus muscle. Of course, you have to irrigate the conjunctiva very, very well with balanced salt solution, and then with a gentle hook, muscle hook, you can just spread the mitomycin all across so that it spreads very well. Now, Dr. Sehota is also, since a long time in RP Center, they have been following this method. Instead of giving 0.2 or even going up to 0.4, where I'm sure they do only 0.4 in certain number of cases, in certain particular cases, they have found that just 0.1 milligram per ml works equally well, and it is non-inferior to the oft-repeated 0.2 milligram per ml. So only thing is, they've said you take a wide area of MMC in order to avoid localized blebs. And now, what are the other modifications available to us? And one of them is that we can use amniotic membrane. And I'm quoting a paper of Dr. Kirti itself over here, and I've used it in several cases, and I found that, for example, in a case of Axenfeld-Briegers, the boy who was only 15 years old, and we find that he had myopia, and I didn't know, now what should I do? Okay, AMT came to my rescue, and I'm just going to show you another modification which we all do, phacotrab. But one site, two site, I prefer the two site method, and in that also I have been able to use micro AMT. So AMT has immense amount of use, and so just let's have a look, a very, very, very brief video as to how we have done it. And again, the same method. I like a triangular flap, partial lamellar flap, scleral flap, and go nice well into the cornea. And then after that, may put in my horizontal mitomycin strips, then go to another site, do my phacoemulsification, and after that put in my lens nicely, then I'll close my wound, and after that go ahead and complete my trabeculectomy. And then, of course, I found that there was a little thinning of at the sclerostomy site, and therefore I took my amniotic membrane, cut it, and very simply put it over there, and you can either suture it over there with 1 or 2, but I found that yes, even if you don't suture it, lay it out nicely and take it in your conjunctival suture, you find that you can even do it. So this is a very, very good method of using in trabeculectomies. Moorfield Safe Surgery System, as mentioned by Ko and all, is a very, very good thing. And most important thing is what he says is, make a rectangular, scleral, horizontal incision parallel to the limbus, dissecting at partial thickness, scleral pocket, cutting the two sides. Don't complete your side incisions right up to the limbus, so that it helps, everything is being done in order to direct your aqueous backwards and posteriorly. And also very important is that he uses a clamp. Yes, we don't have money to use a clamp, but we try not to affect the cut conjunctiva. And then most important is that they put an adjustable suture. We all do releasable sutures. So without a releasable suture, I can't get sleep. So I prefer my Wilson's releasable suture. And as I've shown in the figure out here and in my video also, there are various other methods of putting releasable suture. One can do it the way we want. Another thing which is very much in position, which people have used for a very long time, is Ologen. We know Ologen is a type of type 1 collagen, glycosamine. It has a nice pore. It helps to direct the fibrosis nicely. And here is the picture of a patient whom I had done probably in AFMC long ago. And the Ologen sort of remains in position. One has to know where to place it and how much of suture tying and how much of tightening one has to do. And now, fortunately or unfortunately, Ologen has taken another person on its site. So 2 Ologens have been used by Angmo et al. In RPC, and they are placing an additional implant under the scleral flap, placed in a scleral pocket. This helps to maintain the intrascleral aqueous lake, reduces the adhesion between the lamellar scleral flap and the scleral bed, augmenting aqueous flow. They feel that it is definitely better. Now there was another add-on, which again the RPC people, they have shown us a way. In fact, with mitomycin with Ologen, subconjunctival Ologen implant, they found was insufficient to achieve a low target pressure, as it covers only a small area in the conjunctiva. There was fibrosis around that. So they combined Ologen with low-dose MMC. anti-vascular endothelial growth factors, amniotic membrane, other biodegradable implants. They prevent fibroblast action. They modify wound healing in a safer way. Now, there is another method of doing a trabeculectomy, another modification by Sihota and all, who's done it long back in 210, and I have personal communication with ma'am. She says that I can do it in various types of surgery with very good results, where they have done an ab externo cyclodialysis with a trabeculectomy. They have done it mainly in post-keratoplasty eyes, which we know are extremely difficult to for controlling the intraocular pressure, but she has done it in other conditions also, stating that it is very good, and in post-keratoplastic eyes, there was no decrease in graft clarity, no graft failure, even in eyes followed up for 2 years or so. Now, more the merrier. So we have Dada et al. They did a trabeculectomy with cyclodialysis and a 3-site implantation. A 3-site implantation of Vologen, subconjunctival, subscleral, supraciliary, that is within the cyclodialysis cleft in eyes with advanced glaucoma. And I'm reminded of what Dr. Vanita showed yesterday, where she combined procedures and found the effect to be extremely good in advanced glaucoma. Am I not right, Vanita? So here it is that they have used 3 techniques and found that it is better. They have also used an illuminated microcatheter assisted circumferential trabeculectomy, trabeculotomy, and we know that the method which is mainly done in congenital glaucomas is trabeculectomy with trabeculotomy. Here they used a microcatheter with good results. And this is a video which I borrowed from Dr. Tanuj, because I found this thing very interesting. Way back in 2010 or so, we used to do deep sclerectomy. Then, because its pressure difference, it was not too good. That is why we stopped doing it. And here we find that they have utilized deep sclerectomy with trabeculectomy in order to improve the results of trabeculectomy. There's device-modified trabeculectomy also, and in which I will just try to show you. Can I just finish up this, my last slide? And this is a device-used one that is an express shunt. Again, express shunts are no longer being, probably in India at least. And here you can see, this is a very, very old video of mine, which are done in Base Hospital, Delhi Cant, and it works. Because now these patients are still coming to me, and I find that the pressures are maintained on drugs. So it is not that it does not work, and it's a very safe surgery, and you can see actually the result that nicely the aqueous is draining out. And here you can see the aqueous shunt. This is probably 2 years post-op. Thank you so much for your patient hearing.
Thank you so much, ma'am, for highlighting the nuances of one of the most commonly done surgeries by our glaucoma specialists, and also enlightening all of our audience on how to make it safer for a long-term effectiveness. I now invite Dr. Vanita Pathak Ray. Madam has been a pioneer in doing endocyclophotocoagulation and tube shunts for the longest time that we've been here. And our very own Professor McGonigal will talk about how tube shunts are here to stay, but with what modifications. Over to you, ma'am.
She's a pioneer in many other things also.
Thank you very much. I have no relevant disclosures. So let's dive into this straight away. GDDs that are available in India and their relative surface area. As you can see, the valved ones are the smaller ones, Emmet glaucoma valve, FP8 and FP7. On the other hand, you have the non-valved ADI and the Emmet ClearPath 350, and somewhere in between the non-valved Emmet ClearPath 250. What is the difference, relative difference between the two? Of course, the valve one has a valve. On the other hand, the non-valve ones, the chance of hypotony is more in the early phase, so you need to use standard means to control, hypotony. Plate size is smaller in valve. We have already talked about it, and the advantage of that plate size is that it can be placed between muscles, whereas you have to dissect out muscles in the larger plates. And the disadvantage of this small plate size is that it, you cannot achieve low target IOP. That is not the case with non-valved, and the hypertensive phase kicks in much earlier with the valved. So how does the non-valved one work? There is a fibrous capsule formation around the plate, 4 to 5 weeks. This then acts as a reservoir. Between the capsule and the plate, you have aqueous, which then diffuses out passively. And this, of course, does not happen. This takes time, so that therefore you occlude the tube. IOP reduction, therefore, is dependent on the surface area of the capsule, and that, of course, is dependent on the end plate size and the thickness of the capsule. So when you want lower target IOP, you can, or you achieve lower target IOP when the capsule is thinner with larger surface area of encapsulation. But why do we need GDDs? Of course, for refractory glaucomas. What do we mean by that? These are ones that you cannot control with medication or even with oral, and where TRABs have actually failed or deemed to be failing. There are in these eyes more risk factors for failure of filtration surgery. They tend to have more inflammation, or tend to have membranes growing over the angle, or tend to have conjunctiva that is not virgin. And usually it's a combination of the above. So we need GDDs in refractory glaucomas, and you name it, post-surgery as well. Silicon oil, not very uncommon, this feature. Post-trabeculectomies also. I have done many post-trabeculectomy, and this is drug-induced cicatricial conjunctivitis. Forget about the fornix. Look at the bulbar conjunctiva. There's subconjunctival fibrosis. So you do it in neovascular glaucoma, post-VR surgery, post-PK, aphakic, pseudophakic, post-trauma, ICE syndrome, uveitic glaucoma, chemical injury, K-pros, post-fail filtration, you name it, actually. All these glaucomas are difficult to control. So here I'll take you through AGV first. I think most are familiar, but basically this gentleman, young gentleman, had NVG post CMV retinitis, and you can see the anterior chamber filled with blood, and had uncontrolled pressure, of course. What I do is I pre-place my suture 10 millimeters posterior, 60 vicryl, and then I pass it through the holes and then tie it off. I did a vitrectomy to clear off the clot and entered into the sulcus 2.5 millimeters, 3 millimeters posterior to the limbus. And then, you trim the tube, you go into the sulcus, and these steps are standard for all tubes. So let's have a look at ADI. There will be more in the next IC, but you have to clear off the muscles. You have to isolate them. You have to clean underneath them. And I prepare the plate a priori. I first check patency, then I occlude with ligature, and then check occlusion. Following this, I make fenestrations in front of it and check that it is actually draining in front of the occlusive ligature. You can also leave a vicryl stent, as you can see there, and you can check the drainage again. What you also can do is reduce the size of the lumen by placing a 4-0-proline inside the tube lumen. And after that, you carry on with your usual plate preparation. I'm not going to take you through it once again. Once the plate is placed under the recti muscle, I fix it 10 millimeters posterior to the limbus, and once that is done, the rest of the procedure is more or less the same until you actually, if you have a ripcord, what you do with it, you put it into an inferotemporal pocket, that is if you have a supratemporal implant, and I tuck in the free end under the patch graft. And of course, it's closed routinely. So what are the newer inventions? It's, the ACP250 is very useful for two reasons. It's non-valved, so you do tend to get lower IOP. And the second is, it can be inserted between two recti. You don't have to dissect out the muscles. And the eyelets for fixation are rather anterior. So 6 millimeters is good enough. You don't have to go 10 millimeters. So let's have a look at what other advantage you have with ACP250. You can fold it like a taco. It is so pliable that you can fold it, you can hold it along its longitudinal axis, and you can place it through a very small conjunctival incision. So that's another advantage. Have a look here. I have only opened 5 millimeters of the conch. And once I have prepared the plate, I don't want to show that again to you. I've already shown that, all those features. And this folding, I will show to you in slow motion. You can see how easy, how pliable it is. You hold it, it's with a handshake technique, and then with your right hand, dominant hand, you then hold on to the long axis of the plate and then insert it into your pocket, 5 millimeter pocket. It's folded like a taco. That's what they say. This is a taco technique. And once you have placed it, what you can do is just unfold it. It's very, very advantageous. In eyes, this was the drug-induced cicatricial conjunctivitis where it happened, and the rest is all the same. With the ACP, there is also a ligator block. Ligator block helps you. It's a very pliable tube, so you can tie it off, and you can also make the fenestrations after having, after placing it on the ligator block. Then look at this small incision that I made. You can see end to end the vicryl. It's only 5 millimeters, and the tube is doing very well. So the comparative conjunctival incisions of different AGGs, this is for AGV, that's for ADI, and this is for ACP. Right, so the placement of the tube I would talk about is I do a standard sulcus placement unless it's not possible, okay? But in pseudophakics and aphakics, there is no reason why you can't do it. In phakic individuals, if they have cataract, I combine it with cataract surgery, and I certainly do that in ICE syndrome. When they don't have cataract, then of course that can be contentious, but a pars plana tube insertion I only do when simultaneous pars PPV is required. So you can see here I have used a technique where I have inserted the tube in the PI window of a patient's previous trab. You can see the tube there. Then length of the tube, I usually keep it long because it allows for retraction, especially in growing eyes, especially in children. And the tube length, if it's long enough, you can reposition later without using any additional hardware. You can see here in this ICE syndrome, there is a little bit of retraction of this. This patient had actually undergone ADI. So, few more tips that I would like to give you, that in pseudophakic, aphakic eyes, you place the tube in the sulcus, helps to prevent endothelial cell loss. If the eye is aphakic, then even in AGV, I will use ligation, albeit partial. And in silicon oil, I actually do intraoperative fenestrations. I'll show you what I mean by that. The tube never gets blocked, and you can consider removal of belt buckle in consultation with a VR surgeon if the patient has a belt buckle. So why in the sulcus? Look at this AC tube. It is causing, over a period of time, it has caused corneal endothelial failure. This patient had trab and tube elsewhere, came to me with 636 vision. Unfortunately, the pandemic intervened and the patient's vision became hand movement. So I had to use a Venflon tube just be another minute. Venflon tube because it was a short tube, I had to use some extra hardware. So this is a high myopic eye who's underwent RK in the past, has had RD surgery, is aphakic. So this patient had AGV, and I ligated the tube. And here, this is silicon oil. I don't know whether you can see the meniscus there, and you can see that the tube itself is patent. And belt buckle, you can easily remove, as you see in this particular case. So there are lots of complications, of course, with tubes, some which are common to all filters, some which are common to all GDDs, like tube exposure, plate exposure, endothelial decompensation, and tube block. But that's for another day. The key points, therefore, I would like to say, the tubes are indicated in refractory glaucomas where failure with trab is expected. They're efficient, but there can be complications. More manipulations are required in non-valved to keep the IOP under control. And initial hypotony is expected, which should be managed preemptively. Just skip the last slide. Thank you very much for a patient listening.
Thank you, Dr. Vanitha, for taking us to the whole gamut of tubes and the different tubes available. Thank you so much for the excellent videos. And now we have our Harry Potter who dares to go bleb free. He dares a lot of things. He dares to sit with 4 girls and present, always. And he's a master innovator. His surgeries are beautiful as he will take you through the bleb free Schlemm's canal surgery. Over to you, Dr. Siddharth.
Thank you, Dr. Kirti, for having me in the IC with all the beautiful ladies and even calling me Harry Potter. Thank you. Can we have the slides? Yeah, it started moving, right? So I will start with a disclaimer. The disclaimer that trabeculectomy is going to stay as a first choice surgery for most of the patients that we deal with in our glaucoma practice who have advanced glaucomas and need quite a low target intraocular pressure. An example of that is this patient who has progressed rapidly, sometimes getting lost to follow-up, sometimes not being compliant, and you being hopeful that that will change, but it doesn't, and the patient has progression, and in view of the fact that there has been no previous surgery, we will choose a trabeculectomy for a significantly low target intraocular pressure than 14 to 16. However, at the same time, whenever you have a bleb and the patient or the eye has 20, 30 or sometimes even more years to live, you cannot be sure of what is going to happen to the bleb. And because the bleb is going to get modified throughout life. So that is the risk that we always have with trabeculectomy. Another end of the spectrum is this kind of patient where you have silicone oil in the angle. The inferior mirror shows the superior angle. And because the emulsified silicone oil seems that it is limited in amount and you can wash it away, you can still do an implant. Typically an AGV would be preferred in a situation where you have a significant risk of retinal detachment. But in the present scenario, I will not hesitate in saying, though the fact that our main skill as surgeons and main surgical treatment will remain trabeculectomy and implants, the way the world is going to think tomorrow is do those surgeries only when you can't do the MIGs or the MIBs. And these are the various MIGs that you can do. The number of devices keeps getting added, but the basic classification is still the same. You can divide the Schlemm's canal procedures into stenting, dilatation, and trabecular meshwork cutting. And an early disclaimer is the fact that because it is our experience, I have not performed that many eye stents. I have only done 2, and that to a part of demo. We will do more and we will have experience to share on that, but I will limit my experience and talk on the trabecular meshwork cutting, which doesn't seem to be very popular. The advantage of these procedures, especially the GAT and the bang, is the cheap or the economic advantage that you can provide to your patients, which applies to a lot of the population that we see. Also, if you look at the efficacy of the MIGS surgeries in terms of dealing with patients who have high intraocular pressure to start with and gets it to significantly lower levels, start with higher number of medications and brings it down to lower levels, GAT and trabectome seem to have an advantage. The trabectome has lost out because of the requirement for an additional equipment, which is quite expensive. So GAT became our go-to surgery when the pandemic struck and we realized that the patient couldn't come back. And these are the typical indications of performing performing GAT on a patient with open-angle glaucoma. And even those with closed angles, if you have access to the nasal angles, you can still perform GAT. You of course need a microscope with the capability to tilt, a surgical gonio lens, which can be a permanent or a disposable one, which can be reused for a significant time. You can also have options of lenses which do not require a microscope with tilting ability, and those can be used. And you need to have the umbrella tip 50 Prolene suture, which you can also manufacture or modify a normal Prolene suture yourself, a cohesive viscoelastic, a serrated Grishaber forceps used for ILM peeling. Before the procedure, you need to tilt the microscope to around 35 to 40 degrees and tilt the patient's head to get an overall angle of around 80 degrees. Now, this is a GAT procedure being performed in an eye which is phakic, is mid-dilated, probably because someone in pre-ops decided to dilate a patient who didn't need it. So I am going to inject an air bubble, use pilocarpine, so that the pilocarpine goes under the pupil, acts on the sphincter to constrict the pupil fast, and followed by a cohesive viscoelastic. Typically, I use Orogel. Now, the amount of viscoelastic that is left in the eye at the end of the procedure depends on what viscoelastic you are using, and I have found it very comfortable to use Orogel because I have most experience with that. Now, everything, including the MVR blade or the 26 gauge needle that you use, needs to go into the eye before you put the gonio lens. Once you are confident that when you put the gonio lens on, you are going to get a view. So this is an on-fast view, and once you see the trabecular meshwork, you go and make a 1 clock hour long or similar length of incision at the anterior margin. Use the tip of the Grishaber forceps to insert the umbrella tip 50 Prolene, and with a few small movements, you can zoom out and take larger bits of the suture, push it towards the Schlemm's canal, and instead of needing 20 to 25 movements, you can finish the GAT surgery in something like 10 to 14 pushes, because you cover almost more than a clock hour if the resistance is not significant and you are ergonomic with your movements. With time, you have some blood leaking into the anterior chamber. The view may become hazy, so you probably will do better to exchange it if the view is hazy. And you just wait for the blue snake to appear from the other side, and you'll just wait for it and grasp it at the right time. Okay, so you see it, and once you have held the tip with the Grishaber, you just rip the other side off. And this recording that you see is the entire surgery played at 1.5x speed. So when things go well, it can be this fast, and at the end you leave around 40 to 50% of Orogel in the eye to have a blood-free anterior chamber on the next day. So that is a requirement, and most of it gets washed away. Very rarely you get a spike on day one post-op, even with this. Now, even before I talk of my experience, let's look at what the world is saying about GAT. Now, Davinder Grover is the one who actually introduced GAT to us. His outcomes, 3-year outcomes, or 2-year outcomes have come now. The picture doesn't seem very good. 44% of those patients he operated upon the primary open angle glaucoma and secondary open angle glaucoma needed a second surgery. Similar outcomes were published over 5 years from another group in US. At the same time, one group from Turkey has shown that the GAT, when performed with a suture compared to eye track, can have success rates of around 70% at the end of 3 years, 70 to 80%. So it is confusing, and we don't know why it should be different between two countries. So we need to wait out for the results that we have. I am very careful in presenting the results only of the eyes which have completed 1-year follow-up. So I'll probably skip the other eyes and not try to claim. I'll show you the results only because I don't want you to believe that the results are hidden because there are problems in those groups. But look at only the 1-year outcomes. 17 patients, 13 of them without medications, and the intraocular pressure is less than 14 in 7, and less than 21 in 16 of them. So most of them are doing well, and in all counts of defining success, these are successful surgeries. And the results are not very different, with majority of patients going off medications and continue to be off medication. So what is the learning that we have is that people who do well to begin with, they keep doing well. Very few of them go on to fail massively. Most of the failures are going to happen within the first 6 weeks or within the first 6 months. If they survive that period, they are most probably going to do well. This is a list of cases where phaco-GAT was performed in patients with angle closure, where there was some access to the nasal angle, and they are all doing well. My own personal opinion and experience of where GAT doesn't work is, one, uveitic glaucomas, and the second is patients who have very high intraocular pressure to start with, patients who have advanced POAG, young JOAGs, and patients with phakic and pseudophakic glaucomas. Okay, I am far behind time. I will not go into the surgical technique. These are the outcomes of bang in patients with angle closure. I have stopped doing bang for 1 year because Dr. Malik Kahook convinced me that these bang patients are going to fail. But now a few of them have completed 1 year follow-up. It seems till this point of time, all of them are doing well, despite the fact that 1/3 of these 9 patients had more than 270 degrees of angle closure, and most of them are medication free and are in early teens. KDB, I will again skip the video and show you the global opinion. This review study actually shows you a very good understanding of what KDB can do. Unlike other MIGs, it seems KDB does well when it's performed standalone, much better than when it is combined with phacoemulsification. It does much better when the intraocular pressure is high, but not in patients with severe disease. So early glaucoma, high pressures, not advanced glaucoma, mean deviations lesser than 20 decibels. These are the scenarios where you would probably would benefit by performing a Schlems canal procedure. I'll just stop here and will be happy to take questions if there are any. Apologies for overshooting.
Thank you very much for the beautiful surgery that I expected from you, and that very candid observation of 1 year follow-up of your own experience. So open to the house and the instructors, co-instructors for our team, and thank you for sticking to time. We still have around 8 to 10 minutes left. So any questions from the house for any of these scenarios?
I have a question here.
Yep.
So I'd like to ask Dr. Siddharth, like you mentioned GAT and bang not to be done in advanced glaucomas. What if you have an advanced glaucoma of a 0.9 cup, but the pressures are maybe in late teens on AGMs, maybe 20, 22 or something like that, and the patient is progressing on perimetry or OCT parameters? Would you go in for a bang or would you go in for a trap versus tube?
So low teens. Pressure in
Pressure
low
in
teens, but on medication
late teens.
progressing.
Pressure in late
Mid-teens.
teens, maybe?
Mid-teens. Okay.
Mid-teens to late teens, but progressing.
There are 2 reasons why I would not go for a mixed procedure here. One thing is there is documented solid literature in the proof in support of the fact that the intraocular pressures that you're probably going to end up with is going to be 16 to 18. So even if I have patients at 1 year follow-up, many of them who have intraocular pressures lower than 14, they're probably not going to settle in that zone. So there is significant evidence for that. Plus, in advanced glaucomas, the abnormality of the anatomy may not end up with just trabecular meshwork. The distal outflow pathways also probably get affected. Why? And that is why the MIGs don't work as well in these patients, the Schlems canal based MIGs. So I would rather go for a trabeculectomy rather than either bang or GAT for these patients.
You have a question, Vinita?
No, I just want to make a comment based on that. I agree a single Schlems canal or TM-based MIGs will be insufficient for advanced glaucoma, but I am gathering evidence in my own patients where I'm combining it with ECP. So what ECP is doing is reducing the aqueous, and what a canal-based surgery is doing is that it's enhancing outflow. As a result of this synergistic action, it's very intuitive. Most of your combination medications are like that. Ones that reduce aqueous production and ones that promote outflow. So this synergistic action is actually very promising. If you're interested, there is an IC tomorrow morning. I don't want to elaborate.
So then you would want to add something, so just
Yes,
not standalone.
not standard.
I have another question for you, Siddharth. Like when you have, like we have been doing not GAT so much as bank because of our patient profile, and we find that over the months, the cleft tends to close and pus seems to form, but the pressure remains to be controlled. Is that your experience too? Shaina is nodding very vehemently. So is that your experience? Is that the anatomical outlook is not being linked with the functional outcome? Is that your experience?
I think one of the things that has happened with me, because I have done all my banks in angle closure, is that I have kept the patients on thrice a day pilocarpine.
Yeah, I think that's a problem.
So
yeah.
that has prevented the pus from being formed, and luckily
So
neither anatomically.
you've kept them
nor-
all on pilocarpine for how long?
They are always on pilocarpine. I'm very
Oh.
These patients,
These patients
with angle
follow up,
closure,
they are very
these are all
good
angle
patients.
closures.
Yeah,
With some of them have more than 270 degrees of pus, and there is some amount of goniosynochilasis also being
So
performed.
3 times pilocarpine?
I keep
So
them
that
on
means
3 times.
almost, let's say, lifelong pilocarpine.
It's too aggressive, I know, but
Because the
these are
problem with
all-
pilocarpine, number one, in Delhi at least, is it's not very freely available despite all our best efforts. I'm glad that you have it.
These are all
You want to say
advanced
something on that?
PACGs.
Yeah.
No, what I want to say is that, you know, Kirti, it's going to catch up over a period of time.
Yeah.
You will get a little bit of fibrosis because the needle is not precise. No matter what, how precise you want to be, it's not precise, and the cut that you get, unless you actually see a shaving of the trabecular meshwork and you remove it away
That's-
from
yeah,
the eye,
Yeah.
it's very difficult to
So,
say.
but even then, even if you cut it very cleanly, that's normal fibrosis. That's the, you cut something, it's going to
Yeah,
heal. So
absolutely,
healing is a
of course.
physiological phenomena. So it is happening. So does it happen with GAT also, that physiological phenomena of healing? Because it's a physiological phenomenon. You cut something, it's going to scar down. It's going to fibrose. So would that you keep pilocarpine for those patients also?
Not in patients with GAT.
Not
Open
with
angle
GAT.
GAT we don't.
So I think that's an evolving thing. Any of the audience want to? I've just thrown up questions that you start when you're doing something new, because all of us are working on that for the last couple of years, and we are working on that. Any questions, Dr. Sagarika? your
No, I
comment?
just wanted to make a comment that
Yeah.
it's not always that we consider which method to be used for what patient, or what is the pressure reduction, or whether it's advanced glaucoma or not. Oftentimes there are 2 or 3 additional factors, and that is, does the patient have more comorbidities? Can the patient, for example, have, let's say I had a patient who had advanced glaucoma, both eyes, unable to come to the hospital because she's on tri-weekly dialysis, and many other cardiac problems, etc., etc. So now she's unable to put the medicine because she's not able to get the medicine, etc., etc. So when all these things are considered, I think it's not a bad idea. If she had low tension glaucoma, I did stents and I found the pressures to be low. So I know this is not given in the standard things, but when we are looking at a patient, I think this factor
So I think
must be taken
patient,
into
look at the patient
consideration.
as a whole and work for the best of the patient. Somehow, I know trabs are scary. They do have all these problems, but mostly trabs are good. Mostly they're good, and especially we are using amniotic membrane in our setup for the last almost 2 decades, and it's we use mitomycin C very less, and we always use it intrasteral also. So touch wood, we have.
But
less-
Dr.
Patrice,
Sirisha has a
Dr.
comment.
Hi.
Yeah.
Yeah, just to add a couple of points, all of us will agree that there is no ideal glaucoma surgery. Each one of them has their own problems, while all of us are talking today about mix because you have problems with the conventional surgeries. But having said that, if one mix is better than the other, I do not know, because each one to each and how the eye behaves. So just to answer the question that Dr. Kirti asked, do you use pilocarpine in GAT, and you see that sometimes partially the cleft is closed but the pressures still seem to be under control? a lot of things that we don't understand, like some of my patients on GAT have pressures of 10 and 12 over the past 2.5 years. So that's when we started doing during COVID. So they are absolutely nil medication, both eyes IOP of 10. You do an ASOCT, you can see that the cleft is open. Clinically, when you evaluate, when you do a gonio, it's very difficult to see. You can see the cleft, but you do not know if the flap is closed or open. So ASOCT is something that we do, but if we see that there is a pressure spike, do a gonio. You do a gonio and you see that there are synechia developing in one quadrant. I do use pilocarpine twice daily for 3 months. And post 3 months, I believe that the fibrosis is not something that's going to continue. At least the active inflammation in the post-operative period is not going to continue too much beyond that. So post 3 months, I stop pilocarpine. If things are under control, then I don't have to continue the medication. At least that's been my experience. And in whom it works really well. And in those that doesn't work, then you have a problem with any surgery that you're looking at.
That's precisely what Dr. Henri Mahmood was saying yesterday, that, you know, you don't know in which ones it'll work. So, you know, just because it's not working in others, does that mean that you deny it?
In fact, we are doing it now in angle closure, you know, because we find that once, especially after phaco, and we have found till now, it's very early days yet, because as he said, Dr. Siddharth, that uvascular the outflow is damaged at the angle closure, just at the angle. Otherwise, it's fine. So maybe once you can get rid of the angle closure element and it's accessible, which it does become after phaco, it may work. So you keep evolving and learning, and that's what the great thing is. Any other comments from Dr. Shaina, Dr. Anu, and anybody?
Yeah, unfortunately, we all zero in only on surgery. But, you know, this IC was a lot more than just surgery.
It was.
But, you know, it's okay.
So any comment by the audience? Anybody? Otherwise, we'll call it a day. And thank you so much.
One small comment about the medication side effect.
Yeah, Shaina.
It's been a kind of a moderately long time that I've been seeing glaucoma patients on a large scale. 10 years is not a very long time. I'm sure there are people in the audience and
3
definitely on the
decades.
panel.
3 decades.
Yeah. I feel the number of people who are coming with intensely red eyes has become absolutely too much. It's not feeling good. So
Not
what do you
even too
think?
much. What I find, don't start me on my pet horse. One NCT of 30 and you start them on 3 anti-glaucoma medications, you know. Be serious. Try to put 6 drops in your own eyes, guys and girls. Just try to put 6 drops in your eyes every day. It's damn difficult. And what the poor, I call it the sick conjunctiva and the sick person who's giving it to them. So really we need to rethink on that. It's a good point, yeah.
No, I quite agree with
you have a
Siddharth.
comment,
Sorry,
yes.
please.
Just one information, no financial interest, especially for Dr. Vanita.
Okay.
The RD250 is also now available.
Okay, thank
And,
you.
You're not marketing it well.
And
Yeah, and
would love to have the pre-placed stent also in the RD.
pre-placed stent, request, customized, make it customized.
No, stent you can place. That's not difficult to do. Come
He
on.
wants it pre-placed.
You can place it yourself.
No, I think
That's
if
not
anybody
required.
can do it, George can do it.
No,
Okay, any
thank
other
you.
comments? But thank you so much. So can we have a group, can we have a picture for instructors? And then I think we have lunch waiting. Thank you.